So first of all, everybody, welcome to this seminar. This is an ongoing series of seminars that we are organizing with the project that we have is called LIBRE Hub. And this opportunity we have Dr. Marcelo Andia. He's a faculty of this university, Universidad Católica, in the Department of Radiology. And he has been involved with medical imaging for a long time. As he's a PhD and MD, so he has like both views of the medicine. And I think that with that we can go ahead, Marcelo. Thank you for your time.
Oh, thank you very much for the invitation. Super happy. Thank you, Tobias. Thank you, Pablo, for allowing me to show what I love to more. Second, my wife first, and this is the second one that I love in the life, which is imaging and all of this implication. Just to begin, first of all, of course, I'm sorry because my English is not perfect. I all the time say that I have a British accent. It's the south of London. It's 30,000 kilometers south of London, my accent. So sometimes it's not very good, but I will do my best today. And what I want to talk today to you is something that always happens in clinics, and is this difference in the objective of research in imaging, the different point of view from the clinics applications and for the what do you want to do for research. And sometimes these two views don't talk, and we have this mismatch. This is why I call this talk today "Sometimes more is not better," and I want to show you why we most of the time we're thinking of that. First of all, let me. Okay, in medicine, we all the time want more. Probably you have been a patient sometimes, and when this doctor say maybe you could have this disease. Well, doctor, I want to test. I want to be sure that I don't have or I have this disease. So all the time you want more. And maybe you go for an X-ray, and then you want to go for a CT, or maybe a magnetic resonance, or there is any other new technique, more specific, and always there is more. So sometimes this in medicine, when you put the limit, you say, okay, from the clinical point of view, this is the limit, and we don't need to do more. But always this boundary is not very clear in clinics. And let me show you this example. This is how the cost or the expenditure in healthcare has been increased since the 90s, the beginning of the 90s to today. And you see how it's growing every year. This is the percentage of the GDP that every country invests in healthcare. And it's only increased. And as you can see here, of course, the United States is probably the place where the healthcare is doing the worst in terms of how much money do you invest in order to get healthcare for your people. But all the time increase more and more and more. So this is a huge problem. And usually what happens is that you invest a lot in a small group of people, usually the people who can afford from some private system. And most of the people in the public system usually has bad quality healthcare, and usually not bad quality because the doctor are bad or the nurse are bad. It's mainly because always we arrive to their disease late, and we cannot do the best treatment or the best diagnosis for them. So this is a huge problem. Additionally, here, let me show you this graph. This graph shows how the price have changed since 2000 until 2024. And you can see how some costs have decreased a lot. For example, the cost of the mobile phones or the computers. You see how all the time you can buy 1 terabyte of information every year, cheaper and cheaper. But healthcare is rising all the time. Different reasons. One reason is, of course, people are getting old. We have old, the population is getting old. Of course, they have more disease. Of course, it's that more complicated patients. So we need to spend more every time that they go to the hospital. But also, it's because we have new technologies, and we want to use these new technologies. And also, these new technologies are very expensive. And this is why the hospital and all of these medical care system are rising the cost very, very sharp. So we need to really think, what are we doing wrong? And there is many books and many people thinking of that. And I just advise you, if you have time, to read this book, which is very catastrophic, but it said something very, very, very clear, that I think we are doing very wrong in our actual healthcare system. In Chile, if you live in Chile, you know that all the problems that we have in FONASA, which is the public system, where most of the hospital in September run out of money because they don't have the proper budget to do the works. Or the ISAPRE, which is the private system, is broken. It's mainly because the costs are rising too fast, because we're not using our brain to develop which is the better for the population. And we are only use the best technology for everything. And usually, sometimes this is not the best idea. And let me begin with a few examples. And this is a very nice paper in Lancet. It's a very new paper where they show you all the medicine service that we are overusing. Sometimes you say, doctor, maybe I have a headache. Okay, let's go for a magnetic resonance imaging. It's 500,000 pesos, Chilean pesos. Why I didn't need to do that if I only have maybe it's just, I have a flu, or maybe I am a bit stressed. Why I need to go for that? Maybe you have something more, but do I really need it? Probably not. You don't need it. And let me show you. Probably you don't see very well this image, but I want to emphasize some of them. And here you can see this is all some of the diagnosis technique that we use in clinics, but we are overusing. We're using this technique in patients that doesn't need it. Don't need this technique to do the diagnosis. Or maybe we are repeating the technique, the diagnosis technique, more often than it's necessary, mainly because there is different interest. Of course, the clinics want you pay the magnetic resonance imaging. The doctor want because probably some percentage of the imaging go to his wallet. So there is different pressures of using this technology. And just let me show you a few of them. For example, this angiography, the coronary angiography. I don't know if you know, but if you have a chest pain, it could be that maybe you have a plaque in your coronary. And in order to do a diagnostic, I need to put a needle going from some of your arteries, usually from your arm arteries or from your leg arteries, moving the needle until your coronaries, inject contrast and get a picture of your coronary branches. But more of the 25% of this technique doesn't need to do it. You don't need it, or you do it in a patient that doesn't need this technique. This technique is super expensive, and also not only expensive, it's exposed to the patient to a very high risk. You can damage the coronary, you can induce an arrhythmia in the patient. So it's not something that you can do just in case. No. You need to do it in a proper clinical scenario. It's not something, but we are doing more than we have to do it. Many imaging in, I don't know, prostate. Prostate is a very, very nice case where we do a lot of imaging in prostate cancer, but we don't need it. We truly don't need this imaging, and the people are expending a lot of money, and we're using this equipment to get some, I don't know, MRI of your prostate when you really don't need it. And maybe somebody who really needs the image don't get access to this machine because it's busy because of you. This is the huge problem. And this is what I love it now. It's this vitamin D, paranoid. I don't know if you have children, so are you going to the doctor? And in Chile, that is crazy. Everybody is measuring the vitamin D levels. And all of us are under the levels. So everybody is stressed because vitamin D is related with everything. I mean, even if you're happy or not, even if you are, I don't know if you have cancer or something. I mean, it's because they changed the value, they changed the level. And it was a very bad decision, and then now they come back to the level. But sometimes from the night to the other day, everybody of us has a very low levels of vitamin D, and the people are doing tests, and I give you a boost of vitamin D, which is not necessary at all. All the study has shown that there is no benefit to do that. And here, for example, MRI imaging. MRI is a super expensive technique, super expensive, extraordinary technique, but super expensive. And most of the, it's about 80% of the patient are doing MRI from the back pain, and you don't need it. It's obvious that you don't have everything bad. It's just, you do a wrong force, or maybe you do a sport without training, but you don't need to do MRI. But in Chile and in US, in the world, you are still doing this technique when you really, really don't need it, putting a lot of pressure on the healthcare system, and usually don't give it access to these techniques to people who really, really need. So at the end, this is a huge, huge healthcare problem. And in Chile, we have plenty of this kind of decision. Just here, for example, a study in UK has said that in UK, they spend more than £5 million every year try to take off this wisdom tooth when you don't need it. You don't need to take it off, but they still doing the surgery and take it off. They don't give you any benefits, but you spend £5 million in this kind of technique. Here is something that we call the cesarean, which is this technique to deliver children. And in all the countries, you need no more than 20% of the mothers should deliver her babies by cesarean. 90%, 85% should be by the normal delivery. But when you have the wrong incentive, for example, here in Chile, we have a rate of almost 50%, which is completely insane, completely insane. You don't need this technique. It's not good for the mother. It's not good for the baby. It's just because we have the wrong incentives in the wrong place. You need to show that this produce any benefits, and there is any study who have shown that because of this 45% or 50%, we have better deliveries than in other countries. It has been shown that it's not true. And also medical errors is a huge issue because we do a lot of things that we should not do it. And in US is considered medical error the third cause of death of the people. I mean, this is how important it is, this disease. Let me give you an example linked with imaging. Until 2014, we used these clinical guidelines, and the clinical guidelines says if you are a smoker, you should have a chest X-ray annually to detect early lung cancer, which it probably makes sense. I mean, if you smoke, and because you smoke, you have a lot of problems or a lot of risk to have lung cancer, maybe it's a good idea to do a chest X-ray every year just to be sure that I don't have cancer. And we use this guideline until 2014. Every people who smoke, we say you should do an X-ray, thorax X-ray every year. But then you ask yourself, this is a benefit for the patient? Is really necessary to do this? And they do a study. In 2011, a group of doctors asked, it is necessary to do that? And they create this something that is, I hope today you can get this idea, is something that we call randomized control study. Or it's a design of a study when you have patients and you randomly assign this patient to two different treatment or diagnostic method or whatever, and then you test the difference between these two interventions. And they take this population of people who smoke. Half of them go for the classical care. Go to the doctor maybe will put his phoneendoscopius in your thorax and ask you if you breathe normally, if you sleep well, okay, go home, and nothing else. And another group go for this chest X-ray every year, which is the hope. And in this group, you will detect more cancers than in this other group. And of course, these people will die less because of cancer. This is what you want. This is what you are investment in, do a chest rate every year. So this group of researchers identify this patient and split this in these two groups and follow them for 20 years. And what they have found, here in this black line, you see the smoker people who were followed every year with a chest X-ray. And in the dot line, you see the people who has the usual care without chest X-ray. And in this X, you're looking at the people who die because of cancer, of pulmonary cancer. And as you can see, there is absolutely no difference. Doing the X-ray, the chest X-ray every year, don't give you any clinical information to anticipate the diagnosis of cancer. The people die in the same way if you don't do it. So don't do it. Stop doing that. Don't expend your money in that. It's much better to expend this money in a treatment to quit smoking, of course. And don't use this machine, the X-ray machine, to other people who maybe need it more. But don't use it to do a yearly, annually chest X-ray to a smoker, because this technique doesn't give you any information to improve the health of the patient. I hope you, and this is the design. This is the design of the study that you need to do when you create new technique of imaging or whatever. Well, some people say, oh no, we're not happy. I mean, if this people is a smoker, we need to find the cancer, the lung cancer earlier. If not with X-ray, let's do it CT, a full CT of the thorax every year, just to check if you can detect the cancer earlier. And then they did the same design. You take your population, half of them go for the thoracic CT annually, half of them go for the usual care. And of course, if you do X-ray, you get this beautiful 3D image of the lung of the patient. What happened with the study? They have to stop the study after 3 years of follow-up, because the people who smoke and go for an annually CT of thorax are getting more mortality. You are killing the people doing CT. And it's very obviously because you have a damaged lung, because the people is smoking, but also you are exposing the people to this huge amount of radiation. So what we call the two hits. First, you hit your lungs because you are smoking, and second, you hit your lung because you are doing radiation. So the people die younger because you are trying to detect the cancer earlier. So they stop the study and, of course, say to the world, don't do this because it's even worse for the patient. So they started thinking, well, what happens if maybe we can do a low dose CT? I mean, the same CT with the same idea, radiation like in a circle, radial radiation, then the radon reconstruction, and then you get this beautiful axial imaging of the lungs, but with less radiation. Of course, most of the radiologists say this is a very, very bad idea, because here you can see the full radiation CT, and here you can see the low radiation CT. You see, blurry, there is a lot of noise, the signal to noise ratio is super bad, so don't do that, it's a very bad idea. We need to do this beautiful image and sharpest borders. This is the way we can do diagnosis. In this quality of image, we cannot do a proper, don't do that. And this is what happened. But look at the difference in the radiation of the patient. This is the conventional CT. You expose the patient to 8 millisievert. Millisievert is the unit to measure how much radiation are you exposed. And here you can see the low dose radiation. You decrease this until less than 1.8, 1.7 millisievert. And you get a bad quality image, but maybe it's enough to get a good diagnosis. Most of the people in the very beginning said, no, there is no way. You cannot do a proper diagnosis with this quality of images. And this is when you need to change the paradigm. And they put a lot of pressure and say, yes, we can do that. And you need to change this paradigm. We need medical images to the image look perfect, or do we need medical image that allow for diagnosis? And this is a very huge question. We are working to improve the quality of the medical image, not with the idea that the image looks good. It's with the idea that the image allows us to do better diagnosis. Maybe it doesn't look good, doesn't matter. But if it allows you to do the diagnosis, this is what we need in clinics, not that something that looks necessarily beautiful. And of course, many people working with this low radiation CT, this very blurry, this very noisy image, they develop a lot of fancy works with, and now that development techniques that you use only they reduce the radiation dose in 75%, and then you can get this low dose of CT. And look at this. Now I'm showing you here, this is the normal CT, this is the low dose CT. This is the normal CT, this is the low dose CT. I cannot see the differences. They look absolutely the same for me. And you create, we were still working in the high doses CT. If we were not thinking it, we don't need good image, we do diagnosis image. And with this idea, now they run this study, beautiful study. So now they do the screening of the people who smoke, not with the X-ray, because we know that doesn't work, not with the full dose CT, because we know that it's worse for the patient, but now with the low doses CT. Is the low doses CT screening in a smoker decrease the mortality of lung cancer? And this was the study published in New England. Look at the numbers. They enroll 50,000 people to do that. 50,000 people. Only just have an idea that all of these tests and everything cost around $1,000 per patient. So you can do the multiplication, and how expensive it is studies is something like you need to 400 funds to do this study in Chile. And beautiful. Look at here. Here you see the low dose CT. Here you see the people that are following with chest X-ray because they compare against chest X-ray, and you detect more cancers than chest radiography. But more important, more than detect more cancer, the death of lung cancer decrease when you do the screening with the low dose CT. So now you can see that the low dose CT decrease the mortality of patients with smoker patient because of lung cancer. So this is now a public intervention that you have to do as a screening. So now the recommendation said, if you're a smoker, you should do a low dose CT every year in order to detect, because now we have the evidence that even the image doesn't look completely perfect as a full dose CT, but it allows us to detect this lung cancer earlier and save your life. So this is the way how we need to think when you want to do some interventions. Another example, thyroid cancer. I don't know if you know what is the thyroid, but the thyroid is a small gland that we have here in front of our neck. Here is the thyroid, very, very important gland. And of course, as any other organ, they can have cancer. And this cancer affects young people, usually people between the 30s and the 60s. And more women than men has this cancer. So it's a cancer which is very biased against young women. And of course, we don't want young people get cancer, so we need to do something. And of course, the best way to diagnose thyroid cancer is with echography. You do an echography in your neck, and here let me show you how it looks. This is how looks the normal thyroid in your neck. Here is the trachea, here is the thyroid, and here you see the lobe and the isthmus of the thyroid. So you can see it very well when you do ultrasound. And here, compare this normal, very smooth, very regular gland. Again, this gland, which is a bit, the volume is increased. And here you can see this lesion that probably suggests that there you have a cancer. And as soon as you have this image, probably you need to go for a CT in order to identify better the nodule that you have there. And then you need to go for a biopsy just to be sure that it's a cancer, and then go to a surgery in order to remove the thyroid and then supplement you all the hormones and everything, and probably you will be safe of cancer disease. So works. So with this idea, the South Korean healthcare said we need to do this thyroid ultrasound to every every people yearly in order to early detection of thyroid cancer, because it works. So they do this in South Korea. And look at there. Here is the diagnosis of cancer in South Korea since the introduction of this screening of looking for in healthy people that present the early sign of thyroid cancer. And look at here, they introduced this technique in 2000, and look at how the number of cancer they detect. The number of cancer increased by 7. So they increase a lot the number of people who has cancer in the thyroid. So you can say, well, so the technique works fantastic because now we identify more cancer. Yes, that's true. But when you see if this diagnosis impact in the mortality of people because of thyroid cancer, it doesn't affect at all any single change in the mortality rate because of thyroid cancer. So all of this effort to looking for the cancer, to get a biopsy, to do the surgery and everything, it didn't impact because probably most of this cancer were, of course, it was cancer, but probably will be a cancer who will grow very slowly, and maybe you will maybe when you die, you are not dying because of the cancer, you are dying with the cancer. So you don't need to do that. And this study showed that we don't need to do this screening. You are going to spend a lot of money doing CT, ultrasound, biopsy, surgery, and the impact in mortality is 0. Use this money in another healthcare needs. Don't do it. So you need to think in that every time that you are doing any research in healthcare. And this is the classic New England paper said, okay, with this Korean cancer screening, they create this cancer epidemic. Suddenly, you can see here, suddenly the people has cancer by 7 times. They increase the diagnosis by 7 times. But they are not real. They have no impact in the mortality at all. So it was just a fake epidemic. And overdiagnosis. This is the word that I want to get this idea of overdiagnosis. So far in the world, there is just few screening that really have shown that this really works. The mammography, for example, is a good test that have been shown that decrease the mortality of a woman, and usually it's only recommend in women between 50 and 75 years old. And yearly, you need to do this mammography, and this decrease the mortality by 20 to 40%. So this is something that you need to do. The cervical cancer screening, the PAP, the Papa Nicolau, if you know that, is also a test for screening. You look for in all the women, not in women who has symptoms, no, in all the women, and you do this Papa Nicolau test and decrease the mortality even until 70%. It has a huge impact because you detect the cancer. The hypertension screening. All of us who are we are older than 50 years old, we should go for a hypertension screening in order to detect the hypertension. Remember that the hypertension doesn't hurt. The hypertension doesn't pinch. So if you don't measure, you don't know that you have hypertension until some of your little artery just explodes. So this is the worst scenario. And also the newborn screening, we do a lot of, when you have a new baby, you very early when they arrive to this world, you put a needle inside of him, take blood, and you do these 3 tests: the congenital hypothyroidism, the phenylketonuria, and the sickle cell disease, because has shown that the early detection of this disease improve a lot the survival and the quality of life of the newborn. So maybe this is only the 4 one that really works. Most of the rest doesn't work too much for global screening. But now let's move to clinics. So let's forget about screening. Screening was looking for a disease in people who doesn't have symptoms. This is the key idea of screening. But now let's go to the clinic. Today I couldn't move my hand. I wake up in the morning, I feel really bad, and suddenly I couldn't move my hand. Oh, maybe this is a stroke. You should go to the emergency room. And stroke is a huge issue. It's when some of your artery that goes to your brain suddenly are stopped of the flow. For any reason, there is different ways. Sometimes it's blocked. because you have a plaque there, and that is called ischemic stroke, or maybe some of the vessels that go to your brain broke, is open, and this is something that we call hemorrhagic stroke. And in any of this case, some areas of your brain are not getting enough blood, are not getting enough oxygen, are not getting enough glucose. So this area, these neurons start getting starved. That doesn't have oxygen and glucose, and they slowly decrease their activity until they die. And in stroke, time is brain. Every hour, every minute that happens, it means that your brain are losing neurons. And so you need to do a very quickly diagnosis, and then need to move very quickly this patient to treatment. And we have a small window, only 6 hours. Since you start with the symptom, until 6 hours, we can do something. We can save some of your neurons. After 6 hours, we only can control the damage. We are not going to save any of your neurons, but we're just stop the growing of this area of ischemic area and keep everything calm. But the window is very small, so it's very, very narrow. So we need to do quick diagnosis. So this is critical. It's a really a real emergency. Here, this is the classic paper who said time is brain in a stroke. And here you can see that every second since the stroke starts in this patient, you lose 32,000 neurons every second. Per hour, it's estimated that you lose 120 million neurons per hour. And look at that. If you have a patient with a stroke in front of you, every hour that passed since the start the symptoms, you are adding almost 4 years of age. The people is like accelerated aging for 4 years. So when you have a stroke without treatment, probably you accelerate your aging by almost 40 years. So you have a people of 40 years old, and after the stroke, his brain looks like people of 80 years old. So this is how important is this disease and its diagnosis. Until 2000, more or less, CT, computed tomography, was the gold standard for the stroke. Until 2000, 2005, where we are seeing that MRI, magnetic resonance imaging, get better results. You can identify early damage in the brain, more earlier than CT. CT usually need at least 2 or 3 hours of damage in order that you can see it with CT. But in MRI, you only need 30 minutes, and you are getting what is going wrong in this brain. So you need to improve that. If you want to do an early diagnosis, you have to go for MRI. And of course, if in your hospital there is no MRI available, don't move 6 hours to another place. No, because time is brain. So do the CT, do the fastest thing that you can, because we need to do the diagnosis as soon as possible in order to start with the treatment, the right treatment. And so now they quickly changed since 2004 that we stopped doing CT in stroke. We have to do MRI. But of course, MRI has a lot of problems. It's extremely expensive. But all the study, they do simultaneously. Patient go with stroke symptoms. They do CT, they do MRI, and try to check which is better. And they show in large number of studies that MRI is much accuracy, have more accuracy, has less diagnosis doubt. That sometimes you see could be this, could be that. No. With MRI, you get the right diagnosis very quickly. Maybe it takes longer. Yeah, if you do a CT, usually CT takes, 10 minutes. MRI usually takes 20 minutes, 25 minutes. But it's better to wait for these 25 minutes because you get a better diagnosis and accurate diagnosis, more than CT. So you need to go for MRI quickly. And here, let me show you. Look at, this is a brain. This is an image that you see the vessel of the brain. And this image is getting at 1.5 Tesla. Probably you know that, but Tesla is the unit, how we measure how strong is the magnetic field. And this is how looks the brain at 1.5 Tesla. This is how looks the same brain at 3 Tesla. And this is how looks the brain at 7 Tesla. This is why we love high field MRI because you looks beautiful. You see every single vessel. You can do better diagnosis. Of course, if you ask any radiologist, if you ask any neurologist, they all the time say, go for the 7 Tesla. Because we are going to see every single, if you have a little damage somewhere, we are going to identify you with these beautiful images and everything. Yeah. And of course, we get better images because this lovely equation that most of the say this equation that the signal intensity in MRI is directly related with the strength of the magnetic field. So higher magnetic field, you get more signal. So of course, where you are going to get these beautiful images. And if you know, if you see in the news, and this is a paper in Nature, in the French research people developed this 11.7 MRI, human MRI scan. So look at the difference between the 3 Tesla, the 7 Tesla, and the 11.7 Tesla. So if you ask a patient, if you ask a doctor, which one are you going to choose for your patient? You have a stroke. Of course, I want the 11.7 because I want to see any details of my brain. I want to see where is the damage, which neuron can I save because of the treatment and everything. Yeah, it's a good choice. But the main problem is the investment of these machines usually is $1 million per Tesla. So this machine costs $3 million, and this machine probably costs around $12 million. And you can imagine that in a country like Chile or any other country in Latin America, you hardly can buy a 3 Tesla scan. There is no way to buy a 11.7 Tesla. So we really need this kind of accuracy. It should change our diagnosis. If you have a patient that you scan a 3 Tesla, you are going to do this clinical decision, and when you scan to 11.7, you're going to do another decision? Probably not. And this is what they have done in the past. And also, let me show you, of course, the MRI scanner are unique. This is a super expensive machine. It's a wonderful machine, but it's super expensive. And as you can see, it's very unevenly distributed in the world because it's a super expensive machine. In Latin America, there is just few countries with MRI. We are very lucky that in Chile we have a lot of this machine, but you have to be, because this machine are mainly in the private system. Our public system doesn't have too much of this kind of machine. And this is what the idea of that probably you know better, that this MRI for all. I mean, we need to how we can give access to the people to this technique, but less expensive technique. We cannot go for the 11.7 Tesla. Probably doesn't give you any good information, better information that may be a lower field that could be more cheaper, and also you can be spreading whole countries. In everywhere you can have this machine to do early diagnosis. And this is how in the past 5 years, probably, they start decreasing the magnetic strength of the machine. And now, I mean, this is the classic example, the hyperfine with is 0.064 Tesla. I mean, it's just, it's like a dust MRI. It's just one single MRI field per million kilometers square or something. It's very, very low. And probably 10 years ago, nobody will believe that you can get an image from this kind of machine. But now smart people are doing that. And look at this. These are people with a stroke. These people are right to the emergency room. They cannot move the hand. And then you do the 3 Tesla MRI scan. And probably in the T2 weighted, you need to be very trained to identify something, but you can see some edema here. But in this image, we call diffusion weighted image, is clear this area. You can do the diagnosis very well in 3 Tesla. But look at the 0.064 Tesla. Look at the T2 weighted image, look at the flare, look at the diffusion, look at the ADC. You can do the same diagnosis. You can do exactly the same diagnosis with this machine. So we really need to do a 3 Tesla? We really need to do a 11.7 Tesla to get this diagnosis in the emergency room? We don't need it. 0.064 Tesla is enough. Okay, but look at the image, looks blurry. It's not like sharp. Doesn't matter. You know the diagnosis. This is what you really need. You don't need all the details. You know the diagnosis, move the patient to the theater, do the treatment that you need to do, and later you can do whatever you want. 11.7 Tesla, do whatever you want. But the diagnosis, you need to save time, and you need to do this technique available for everybody, as much as people as you can. 3 Tesla is not available. In Chile, we have, I don't know, 10 3 Tesla scan, and probably all of them in Santiago. So if you have a patient with a stroke in Punta Arenas, are you going to transfer him to Santiago to do a 3 Tesla? Bad idea. Every minute is less neurons, so don't do that. But maybe we can buy a 0.064 Tesla cheap scan and put it in Punta Arenas, and then you do the diagnosis there and accelerate the treatment. This is the concept that I want to transmit to you. And now, of course, that is doing a study. This study is running now, where the patient arrived with a stroke. This is doing in I don't know 25 emergency room hospitals, and the patient arrived with a stroke, and they do simultaneously 3 Tesla and a low field MRI scan, just to be completely sure that we are not missing anything important in this diagnosis. The same study that I showed you for the lung cancer with the CT and not CT, etc. Here doing in a stroke simultaneously 3 Tesla, 0.064 Tesla. If we get the same diagnosis, if we get the same accuracy, if we save the same life, the same amount of life, we don't need to do 3 Tesla in the emergency room. We just need the and spread in all the world. This is the concept. This is the main idea of this concept. And again, also here is this beautiful study which is try to get this something called the point of care low field MRI in acute stroke. And maybe I'm completely sure that they will change the way we doing stroke diagnosis and stroke treatment. But again, we're not with this machine. We're not getting beautiful image. Doesn't matter. The image provides you the good diagnosis. So this is what we really do. So in conclusion, just to finish my talk, is we need to break this paradigm. We need better technology, not only to improve the image quality. Of course, we all the time the image looks better, but it's not the main focus. What we really need is to improve the diagnosis capacity. And if you go with better image quality, good. But should not necessarily go with better image quality. And what we really need to demonstrate is we improve the impact in patient health. This is what we really need. So, and also all the time you need to keep in mind that the cost and accessibility is a huge issue in medicine, mainly in our countries. In Latin America, in Chile, we don't have a huge amount of money, especially in public healthcare. So we need to try to decrease the cost and spread the technology in all the country to get better diagnosis. And even if the image doesn't look good, doesn't matter. If get you the diagnosis, you are in the right way. So this is why I just finished to say sometimes less is better. So thank you very much for your attention. I hope I could transmit my ideas and my passion for this idea. And of course, thanks to all the grant who finance to give us money to do all of this kind of research. So thank you very much, and happy to talk about these topics now.
Thank you very much, Marcelo, for your time, and thank you everybody for attending.